I spoke recently at the National League of Nurses annual conference. I was one of their speakers. And in my audience, I had 200 nurses. And so I had my assistant with me, and I said, when I ask this particular question, I want you to quickly count or get some pictures of how many hands go up. And my question to 200 nurses was this: raise your hand if you, like me, have been hit, kicked, punched, bruised, battered, hair pulled, spat upon, scratched, clawed, or had human bodily excrements thrown on you. Raise your hand if that has happened to you. Because would you agree with me that is all workplace violence, right? Right. My assistant could not count the hands that were up. She could only count the hands that did not go up. 190 out of 200 nurses had their hand up with mine.
Are you curious about discovering ways of making your life better? Then welcome to my podcast. I'm Bob Nickman, and this is The Exploding Human. Listen in while I talk with all kinds of people in the fields of personal growth, health and healing, alternative therapies, psychology, spirituality, environment, and the future. I'm looking for those answers that make life better for everyone. You'll meet cutting-edge practitioners, doctors, artists, filmmakers, business people, and those who have overcome challenges. The brave, the curious, anyone who is out there helping us humans to explore, expand, and explode. Hey, welcome to The Exploding Human. My name is Bob Nickman. My guest today is LORRE LAWS, and we're going to be talking about nurse traumatization, nurse burnout, and her integrative health approach to mitigating those things. LORRE teaches nurses and healthcare professionals how to recover from trauma and burnout so they can thrive and not just survive. So we're going to be talking about all the different types of trauma that nurses experience, most of which I didn't really know anything about. It's a fascinating talk because I think that many times people take nurses for granted and don't even realize the extent of what they actually do and how many different types of nurses there actually are. LORRE is really at the forefront of looking at nurse trauma and burnout in a different way. So let's jump in. Here she is. This is LORRE LAWS. LORRE, it's so great to meet you. What a lovely pre-conversation we just had. Folks, you won't get to hear that because it was too hilarious.
We got one going, though. Thank you so much for having me.
Well, yeah, you're welcome. I'm glad you're here. And we're going to be talking about all things nursing. And many of the things that people don't talk about nursing is what we're going to talk about, because you, as in the writing that I got about you in the biography, it was saying something about integrative nursing, and we all know what integrative medicine is, but I never think about nurses in terms of integrative nursing. So why don't you explain what that is, and then you teach this, of course, and how you came to do that.
I've always been a healing arts practitioner, 40 years. And so when I entered the profession of nursing, I was thinking that healing was going to happen, like we were going to be facilitating healing. And what I found was that it was a lot of interventions and a lot of Western medicine sort of fixing things, which is part of healing, but isn't whole person healing, and isn't using all of the modalities that are available to us to be healthy and well. And so I started looking around to see what I could do to align with how I was in the world as a kind of a functional medicine, integrative health person is how I live my life. And so I found 2 postdoctorate fellowships that I did after I completed my PhD. I went and I did 2 postdocs in integrative health. And as synchronicity would have it, at that very same time, the University of Arizona, where I work as a professor, was starting the first integrative health-focused Bachelor of Science program for nurses. And so I knew I had to be a part of that. So what we do is really very similar to functional medicine, only through the nursing lens, is that we look at those in our care as whole people who are inseparable from the context of their life and the systems in which they live and work. And we view nature as having healing properties and integrating nature in various forms into treatment modalities. And importantly, I think we also value that we don't start necessarily with a pill or a procedure. You know, we move from the approach of integrative nursing is to move from the least to the most invasive approach to healing, depending on that patient's needs and context. So if you're just coming out of a surgery, I'm not going to give you lavender essential oil, right? Because that's a different context.
Yeah.
but there's so as kind of matching up, and it really opens up a wider toolkit and a wider way for us to, as nurses, to meet patients where and how they are. Because at the end of the day, we all want to be seen and understood and cared for when we are either well and trying to stay well, or when we are experiencing some sort of unwellness and we want to regain homeostasis. It's really a matter of selecting the right healing modality for the right patient at the right time for the right reasons. And we start with the least invasive and move to the most, depending upon where you are. So, a person who is coming in that has severe anxiety or maybe is having a panic attack, because those come into the emergency room more often than you might think. I would take a different approach than a person who's, say, coming out of the operating room, right? And I would be able to match up a whole myriad of healing modalities instead of just trying to fix something.
What are some of the things that are okay to do as an integrative nurse, and things that maybe particularly a hospital or a classically trained physician might go, don't be doing that in here. This is a very serious place, and we're only doing this, and that's why there's fluorescent lights, because we need to see.
Right, we'd have fluorescent lights and as many noises and as many lights and sounds and alarms to make sure that nobody's rested and centered and grounded in this place.
Hospitals are an assault. In addition to having something wrong with that when you go in, it's an assault. That's how it felt to me. The couple times I've been there, I'm like, ugh, get me out of here.
I've never worked in a hospital, to be honest with you, for those reasons. Is that it was inconsistent with who and how I approach healing. And so I had a private practice as an integrative nurse coach. And so I help coach people through particularly burnout and trauma healing is what I really do. But I was not a good fit for the hospital, although I did do 6 years at the bedside as a certified nursing assistant. So I got my start. at the bedside, and over the career arc, I found where and how I needed to be as a nurse and a nurse scientist.
I always think of a nurse in a hospital in the uniform. I don't think of them. I mean, I think there's home health care nurses. I understand that. But I think aren't most nurses involved in hospitals or doctors' offices?
That is changing a lot. So I think that might at one time, and when I certainly entered the profession in the 1970s, garble.
I wasn't born yet.
Yeah. Oh, come on now. I know from our pre-talk that's not accurate.
No, I'm 70. I'm 70 years old. So I've said that before. I don't care about that. I'll even tell you what I weigh, but I haven't been on a scale, so I don't really know.
Yeah, so there was a time when I think that perspective held true. But now, society has changed. And so we have, people who, and nursing, it's one of the broadest professions. So our scope of practice is enormous. So while we can work in hospitals, and while we can work in clinics, we can also serve as integrative nurse coaches. We can also serve as educators, which I do. We can also serve as scientists. I'm a nurse scientist, and conduct research, health science research. And so we have this huge scope of practice that allows us to, and the beauty of it is that we can have many specialties over a career arc. So if you want to be a pediatrics nurse for 5 years, you can do that. And if you decide you now want to work with people at end of life, you can get more training and take on a new specialty and transition in that way. Nurses they work at insurance companies. There's legal nurse consultants. I mean, and the list goes on. So a huge scope of practice. We're everywhere.
Okay, well, we're glad you're there. This is sort of new to me because I had this very narrow view of what nurses do. But I know that one of the things that you specialize in is dealing with nurses that are traumatized in some way or burned out, and those I really picture being the ones in the hospitals. That's
Yeah.
what I was like, because the couple times I was in the hospital, I saw how hard they worked and what it was like, and they understaffed, and the time demands, and obviously the people in there in some of the worst shape they've ever been in, so they're not that pleasant, including myself when I was in there. So as I mentioned earlier,
Same.
um, I had to apologize to a nurse. I didn't have to, but I wanted to because I was being a little bit too pushy. Is that where most of the burnout comes from, is the hospital nurses, or are we getting it in other places? And what does that look like? And what is nurse trauma? Because I never really,
Yeah.
you don't think about that. You think about, oh, this is a trained professional. Why would they be traumatized?
To answer the first question is that yes, the majority of nurses who are working in traditional healthcare systems, and it's not just here in the U.S. where I'm situated, but I've also done research in Canada and in the UK and in Australia. So very different healthcare systems, and looking really, doing research to find out what was going on with this burnout thing that has been quite frankly, it's been a narrative for 50 years that I've been around, right? And as a scientist, asking some research questions like, why hasn't anything improved in 50 years? Why are we still having the same narrative? Why are we still having the same conversation around nurses are burned out and they need to do better self-care? As if we don't know how to take care of people, which is a little bit of gaslighting, if I could just throw
Yeah.
that little nugget out there. And nurses, you would just if you would just work on your resilience, then
Yeah.
and another term that nurses feel gaslighted by. And so I started asking some pretty big research questions like what is going on with this burnout phenomenon, burnout syndrome? Why aren't nurses, and it's not just nurses. So, I have been talking to primary care providers. I have been talking to mental health counselors, therapists. This is like really a helping professionals problem. Educators, law enforcement, so people who are in the helping professions are exposed to a high amount of trauma exposure. And so you start looking at burnout. So I got really, should I say annoyed or should I say pissed off? I'm not sure which of those. Probably both.
Yeah.
When I looked at
Frustrated.
the,
How about
yes,
frustrated? How
I
about,
was
yeah.
frustrated when I looked at the World Health Organization's definition of burnout, which is it's occupational stress that is not being effectively managed. That sounds a whole lot like blaming the victim here. And so then I started asking some questions around, well, what's the difference between occupational stress and when does that become trauma?
Mhm.
Right? When does high stress become trauma? And while there's no clear-cut roadmap to that, we can't put a thermometer in that because each of us are different and each of us have our own personal and individual lived experiences, which includes trauma. We are to assume as healthcare providers, we are to assume that every person on this planet has experienced trauma, right, in some fashion or another, that may or may not be fully integrated or fully healed. Well, aren't nurses a subset of everybody? Oh,
Yeah.
I think we are a subset of that population. And so I started kind of deep diving to find out, what is this? What are the symptoms? What are the symptoms? Let's take away kind of the narrative, because I feel like the narrative, and I'm not alone in this thought, the burnout narrative is one that keeps nurses subordinate, oppressed, inferior, right? We're not looking at the organizational factors. We're not looking at the system factors that are contributing to the quote unquote burnout, which in my research and that of Dr. Karen Foley at Purdue University, she's the one that actually brought forward the term nurse-specific traumatization. And she has developed the theory that is guiding the clinical studies on this phenomenon. And so starting to look at it through looking at burnout through a trauma-informed lens. Because I was coaching nurses who were experiencing burnout. And what I discovered in my practice is that the usual self-care things that, all of us are working from the evidence-based practice, right? So whether I'm in an integrative evidence base or a traditional medicine evidence base, we're all in evidence-based practice. And so when I am using the evidence in my practice, as many as we all do, and why are nurses not responding to the traditional self-caring, resilience building, let's give you a piece of pizza, at the end of the week? Why aren't nurses responding? And so I started looking at this through the lens of, Stephen Porges' polyvagal theory. I started looking at this through the lens of Robert Naviaux's cell danger response theory, and looking at through the lens of relational neuroscience. So Bonnie Badenoch, Ian McGilchrist, Gabor Mate, so really taking a very comprehensive look at what's going on. I said, I wonder if we started looking, like if we looked at burnout as sort of the tip of an iceberg, I wonder if we would find unintegrated trauma or ongoing traumatization underneath the surface. I got curious about that because as humans, we are genetically and evolutionarily hardwired to withstand short bursts of acute stress. Short bursts of acute stress. But what we have in the helping professionals, and in particular healthcare, whether you're a provider, a nurse, an allied health professional, we're all in that same pressure cooker. And what we're finding is that not only is it prolonged chronic stress, but it is also significant trauma exposure, much of which is avoidable and is secondary to healthcare system or organizational inadequacies. So I started going down that rabbit hole, and like let us peel away some of the layers of this onion, and let me start working with the nurses in my practice, and let's start taking a trauma-informed approach. Let's start unwinding and start healing and giving them the tools to understand through the lens of polyvagal theory, Stephen Porges' work, where we have different circuits and hybrids that we that go online and offline depending upon internal and external uh, situations and stimuli. And so we started working with trauma first and starting to do trauma healing. And then what I found is that there wasn't burnout symptoms. The burnout symptoms sort of fell away. So then I got really curious because now the nurses are progressing. I'm like, well, maybe what if it's not burnout? Let's explore that. And so I did, because, by my job and by my nature, I'm a big old geek. And so let's go down that evidence rabbit hole one more time. And this time, let's do a symptom cluster analysis and take a look at the burnout symptoms. And then let's look at SAMHSA's criteria for immediate and delayed responses to trauma and what those symptoms present as. And let's analyze those. And the overlap was stark and shockingly similar.
Yeah.
Like how, like to the so similar to the point I asked, how can we differentiate one from the other? And it's like, well, you really can't. This isn't something you can get a scorecard out, because as we know, and I've listened to your show, so I know you've had guests on that have talked about how trauma gets stored in the body, right?
Yep.
And whatever doesn't get processed and healed and integrated at the time that the trauma occurs, it gets stuck in the body, in the fascia, in the musculature, in the skin, and in the neuroplexes are the four big places where it gets stored. And so now it's like, oh, that's the wild card, because what's stored in your repository, Bob, is different than what's stored in mine. So each of us could be sitting in the room together and experience the same trauma exposure or the same traumatic event and have different responses in our physiology. Right. And so I call that the repository. So each of us has within us this repository of unintegrated trauma. And then we go to work. Because remember that nurses and doctors and allied health professionals are all part of the collective. We have had individual trauma, right? We're not exempt from being a human. We don't take one nervous system to work and bring it and have a different nervous system for at home. We don't have one vagus nerve work
Yeah.
and another vagus work
Yeah.
at home. And this is that coming back to that kind of holistic, integrative, whole person approach. Let's look at it through that lens. And rather than this narrative, this yada yada gaslighting about, well, you just need to take better care of yourself and it'll be fine. Right. So I started doing some research around, you know, where does nurse trauma fit in the spectrum of professional roles that have a high degree of trauma exposure? Frontline providers. So, paramedics, emergency first responders, we could all say they have a high degree of trauma, and indeed they do. Combat military personnel, yep, they sure do. Law enforcement, yep, they sure do. Nurses, surprisingly, yes, they are ranked among the high trauma exposure. So you start looking at the data around how many nurses have the resources and the support that they need to manage the trauma exposure. Because you don't think, you yourself are like, well, I think of a nurse in a uniform and they're running up and down the halls in the hospital. Like, how traumatic could that be? Right? Because we have kind of what we've seen on TV. Grey's Anatomy is not nursing. but we all have sort of, we've been conditioned to think in the same way that you were thinking. And that's not at all meant to be disrespectful. It just is. It's the isness of the situation.
Yeah, sure.
And so we start looking and we start seeing that 86% of nurses do not have the resources or support that they need to manage occupational related trauma in the workplace. Now, you might be curious, like, okay, well, what kind of trauma? I mean, I don't know. Bob, are you curious? Like, what kind of trauma do nurses deal with? They're not on the front line on a battlefield. What are you talking about?
I could guess. I mean, you see
Yeah.
people in constant suffering. You see people die. You see people have really horrific medical situations that you have to deal with right there. And all within a structure of you don't just leave it at home. Leave it at the office. When you go home, that's on you. Those are human beings that affect us, and obviously people that go into nursing for the most part are people that are very caring people in the first place, or they wouldn't have done it. So that you have this person who's caring, empathetic type of human being, and then they're seeing other human beings suffering in some way and or having really dramatic situations. How do you not take that on and on some level? I guess you got to shake it off and go to the next patient. Well, you do, but there's going to be a residual effect that's going to build. And if you don't discharge that in some way, that's going to be part of who you are now. And if it's an ongoing everyday thing where you're firing cortisol at that level for that many hours of that many days and weeks and months and years, how now I can really see how that would be an incredibly strong effect that, like you're saying, 86% of nurses aren't able to really manage that properly.
Well, and that's just one. And you nailed it. That's one. That's called vicarious or secondary trauma. That's one of the five.
Okay,
Right.
let's go with
So
the other four. So
let's unpack a few more.
tight
Now
shoes,
one, huh?
tight shoes. I don't know.
No, we have Birkenstocks and
Oh
Danskos
yeah, the
for
shoes were good.
that.
Okay, the shoes are
We got
great.
Okas. Yeah, we're fine. Now, the second one, and this one may surprise people, is that there is considerable violence against nurses.
What?
Yeah. Oh, yes, physical violence, and not to mention, lateral violence, incivilities, bullying. Of course, all of that occurs, in many workplaces. So we're not exempt from
Yeah.
any of that. But the physical violence, to give an example, I spoke recently at the National League of Nurses annual conference. I was one of their speakers. And in my audience, I had 200 nurses. And so I had my assistant with me, and I said, when I ask this particular question, I want you to quickly count or get some pictures of how many hands go up. And my question to 200 nurses was this: raise your hand if you, like me, have been hit, kicked, punched, bruised, battered,
Oh,
hair pulled, spat upon, scratched, clawed, or had human bodily excrements thrown on you. Raise your hand if that has happened to you. Because would you agree with me that is all workplace violence, right? Right. My assistant could not count the hands that were up. She could only count the hands that did not go up. 190 out of 200 nurses had their hand up with mine as having suffered that type of physical assault in the workplace. And so that is one form of nurse specific trauma that needs to be addressed. And then it is met with another form and it's not just necessarily nurse specific. I happen to be a nurse scholar, but this is also providers. This is also teachers,
mm-hmm.
helping professionals in general. So it's not just a nurse thing. I just happen to be a nurse scholar. So that's why I'm using that framework. But then you're met with what's called system induced trauma, where the system itself is inflicting trauma upon its employees. So imagine a nurse who, in the scope of his or her or their practice, is assaulted by a patient or family member. Staggering statistics. I have a few that I've put on my YouTube for people who are interested in this particular topic. I have a few, episodes available. Looking at nurses from different parts of the world. It's not just a USA thing. It's a society thing. And so what we are trained to do is that if that happens to us, we have procedures and policies that we have to follow, right? And you take it to the chain of command
Yeah.
and you report it and you do all the right things. And so you want to know what the first question is that most nurses are asked when they go into their administrators or their directors or their unit leader's office?
What did you do to provoke that?
Yeah, what could you have done differently?
Mm-hmm.
I'm bleeding on your desk because somebody came up for me from behind and assaulted me. And you're asking me what I could have. It's like trauma on top of trauma. And now you think about the insufficient resource trauma. So here, as you said, nurses are very caring people. We all helping professionals are. We all find our way because we care and we want to make a difference, right? And so you go to work and you have been trained to provide excellent nursing care to your patients. And this is probably what happened to the nurse that you very kindly apologized to, and you felt like maybe you had been a little some kind of way that you didn't want to be representing yourself in that kind of
Yeah.
way, right?
Mm-hmm. Yeah.
But imagine being someone who's showing up and is being asked to care for a dangerous number of patients.
I can't
You
imagine
know,
that. That's just, I don't
but
even think
like
about that.
Yeah, like if a safe nurse patient ratio, and it varies depending upon the unit, right? So ICU, of course, intensive care unit, you're going to have less patients than you might
Yep.
in another part of the hospital, right? But each area of the hospital, each specialty has safe nurse patient ratios. That is where high quality care is delivered. But you get to work, and let's just say I worked on a unit where the nurse patient safety ratio is 4 to 1. So I should have 4 patients to 1 nurse to be able to care for you and my other patients in a very professional, evidence based, patient centered, heart centered sort of way. So I can be fully present with you when you're having arguably one of the worst days of your life because you're in the hospital and nobody wants to be there, right? But you get to work, you roll in, and you find you have 7 patients. Now, I can't take care of 7 patients the way I take care of 4 patients. So now, so now it's a real conflict, and that's why the title of my book is Nursing Our Healer's Heart, because it's our healer's heart. It's that caring that you talked about. I like, if Bob, if you're in my hospital room, I want to take care of you the way I have been trained, to the full scope of my license. But we are so short-staffed that we have too many patients that we
Mm.
can't show up in those ways. And then we try and we often don't have the resources we need. We go to the supply room and we don't have this. Or I myself had 3 discs herniated in my back because I had a heavy patient that needed to be transferred and they started to fall.
Ooh.
And the Hoyer lift was 2 wards down. And so I herniated L3, L4,
Oh.
L5, and was and so these are what's called insufficient resource traumas, right? And so you think about it, and I call it kind of the trifecta of trauma. So nurses, helping professionals, all of us, we have kind of our baseline individual trauma exposures that comes with being a human. I mean, life is sometimes hard and life is sometimes traumatic. So that's kind of the first part of this trifecta. And then there's the trauma that is unavoidable. It comes with our profession. Like what you talked about was that vicarious or that secondary trauma. Like we suffer along with those in our care. We do. We try to, not absorb that, but how do you not? Right? How
Mm-hmm.
do you not? And so, but we do have some training and we understand, just like trauma from disasters. Okay, that's another one. It's unavoidable. If there's a major earthquake, I do have training as to how to help people under those types of emergencies. So those are the first 2 layers of this trauma trifecta. But what's driving nurses and physicians and all of the health professions from the field in droves is this top layer, which is the avoidable trauma exposure. And this is oftentimes the system or the organizational shortcomings, that, what could you have done not to get assaulted at work? Kind of thing. And it goes on from there, but it kind of gives you this. So it's a very complex. And so then when you start looking at this, and it's like, well, is this burnout? Because when you start looking at it through a trauma-informed lens, there, and you start looking at it through the lens of our physiology, right down to the level of the mitochondria, right? And the mitochondria are the parts of every cell in our body that produces the energy we need to do our thing, to do our human thing, right? Whatever that might be for each of us. But the mitochondria are putting out the energy so we can live. And so when you start looking at what's really happening and why nurses and health professionals and other helping professionals are dragging themselves into work and they're exhausted. And I'm not tired. I'm not talking about just tired because I had a hard day at work. I'm not talking about that. I'm talking about I am dragging myself to my kid's soccer game and I can barely even sit up because I'm just wiped out. I just don't have any
Mm.
energy and I don't know why. I don't know why I don't want to go on date night with my wife tonight. And I don't, I want to do all of these things. But my body just is like so depleted. I'm really struggling, or I'm really struggling to be fully present at work. Well, it turns out that's a physiological thing. we nurses in particular and other helping professionals literally physiologically cannot keep up with the trauma exposure. And
Yeah.
the mitochondria cannot produce enough energy for us to be in that kind of a pressure cooker for that long. If you look at how the military exposes their personnel to violent situations, they pull them in and pull them out, right? You're there for a tour, and then you do some other kind of duty, right? You're not on the front line for 5 years straight,
Yeah.
right? The military's figured that out, right? But nurses and healthcare professionals are being asked to be in a high trauma exposure, different type of trauma. I will, but when you look at it from the midbrain and the autonomic nervous system of the vagus nerve, it doesn't care what the situation is. It doesn't care because trauma to the body is trauma to the body. Right. And how that happens is secondary. I mean, that's what Dan Siegel calls our upstairs brain cares about that, right? Like our prefrontal and frontal cortex cares about that and should. But when you start looking at it from just the physiological impact, the how the trauma happens is not as important as that it has happened.
Mm. Yeah. Like even the type, it might not matter as much as the fact that it's whatever it was, it did happen.
Right.
It's an amazing thing when you have a traumatic situation, how much it lives in you for, at different dissipating levels over time, but it's still there. There was something that happened yesterday on my street where I had to pull a dog off of another dog that was
Oh,
it. It was a giant. It was sort of a pit bullish kind of a dog, and it dragged the woman that was walking it across the street. It had enough leash to do it, and pulled her across the street, attacked this dog,
wow.
and put the dog's head in its mouth. It was a rescue dog. They both were, and the dog and the women were screaming. Both women that were walking the dog screaming, and I ran out and was able to pull the dog off, and the lady got it out of the dog's mouth, and they were both a wreck. Both women were a wreck. There was blood, it was nothing. Nobody died, or the dog didn't die, but
That was a violent event
it
for
was
sure.
violent. So, and I'm sitting there with the woman who had the dog who attacked, and because I know her, she lives in the neighborhood, and she was going a mile a minute about. She was beating herself up for making a mistake of, which she didn't make a mistake. Her intent was fine. She just didn't understand that this dog had that potential. So she goes, I feel like I'm going to throw up, and she's hyperventilating, and the other woman is sobbing, and and there's some blood and stuff, and and she processed it verbally for like 20 minutes over and over,
Yep.
reliving it, reliving it, reliving it, reliving it. Now I'm taking it on a little bit, not much, but enough that I got up today and I was thinking about it, and I felt kind of like, I hope they're okay. And this is not even human beings really that are in a hospital, but they're people that had it, and I know those two women are both a wreck today too. I just know they are. One wanted to go to
And
the
so
hospital and get checked out, and then the vet. I mean, there's all these different things. Is the dog going to get put to sleep because it attacked? There's a lot of stuff on something like that, and this is light in comparison to what goes on.
right.
With
Well, but that's in again, that's like our upstairs brain that is registering that as light comparatively speaking,
yeah.
right? But if we were to examine each of these women, so here's a perfect case study. Thank you for this. So here we have three people. We have three people who came upon the same, arguably a violent and probably a traumatic event for at least one person,
It
right?
was
If
pretty
not all.
dramatic. Yeah.
Yeah, right. So here we have three people, and one of them is externally processing in kind of this sympathetic overdrive. Oh my God, oh my God, oh my God. And I made a mistake. And what do I do? And for 20 minutes is kind of like trying to integrate
Mm-hmm.
trying to integrate what had happened. And the other one is emotional. And you're kind of there being the voice of reason. But I'm sure when you walked out, as you were walking out your front door and across the street, you were in some kind of sympathetic response.
I was running, and when I got there, some sort of a technique survival thing happened, and I screamed at that dog because I know you got to get bigger than the animal. And I
Right.
was like, "Hey!" And I mean, as loud as I could, and I grabbed that leash, and I mean, I was a different person than I was 10 minutes before.
Yeah.
I was in a whole sort of state of hyper alert and hyper
Yeah.
energy and
But
adrenaline.
that's
It was
your sympathetic
yeah.
nervous
So I
system
had to
came on and
unwind. Absolutely, I had to
yeah,
unwind. Yeah,
yeah. And so, and so this is a great case study about how three different people, depending upon what is in within each of our repository, you know, in your repository of unintegrated trauma and life experience, you instinctively knew to get bigger than the animal and to sort of be not the aggressor in a negative way, but the aggressor in terms of getting control over the
yeah. I
situation,
had to
right?
dominate it. Is what
Yes,
I
you
go,
had
if
to
I don't
dominate.
dominate it, I'm not thinking this through. It was just an instinct. If I don't dominate this, something really bad is going to happen.
Right now, imagine you had six other people that you were taking care of at the exact same time.
Yeah, I don't think I could do that I couldn't do that thing that I did yesterday every day without having a big.
Yeah,
Want to know my
yeah,
favorite part of the whole thing?
yeah.
The lady who was walking the attack dog it had a choker on it, a choker chain with prongs in the thing. That's how thick and heavy duty this dog was, and she was pulling on that chain, and she cut her side of her wrist, so there was a lot of blood. And when I was doing the thing, I got the blood got on my pants, right? And she goes, "Oh, I'm so sorry about your pants. I'll buy you a new pair." No, you're not buying me pants. That was
I
her.
know it, but the things that, but this is each of us are responding to trauma
Yeah,
differently, right? And so she's very concerned that, or I'll pay to have it dry cleaned.
yeah.
We hear that, and it's like this isn't even registering in my frame of reference as
No,
something we even need to be having a conversation about, but it's
right.
obviously very important to the
I
other
start.
person.
I laughed. I was like, "No, you're not buying me pants." And she goes, "I think I'm going to throw up." I go, "Go ahead. Why
Yeah.
not?" There's a bush right there. She didn't do it,
Yeah. That,
but it was just a
but that's
lot
a,
of stuff
yeah.
going on. Yeah.
Yeah, and when she wanted to throw up, that was the dorsal aspect of her vagus nerve coming online, and was kind of like shutting her down because the stress and the trauma exposure was so much for her that she her body was needing to purge. Felt like it needed to purge, and I have been in situations where I did have that actually happen, where it's a physiological like, whoop, there went lunch, kind of a thing, and it's really unpredictable. And I'm sad that that happened, and also I'm hoping that everyone is getting. And this is one of the things when we started looking at this trauma phenomenon, and I went over into, I also taught for the College of Social and Behavioral Sciences, so I'm sort of this multidisciplinary kind of geeky girl, right? And so when I was teaching over there, I was looking at relational neuroscience and the importance of having the people that we perceive that we need before, during, and after the traumatic event. Now, I'm assuming that you had your wife that was home with you, and I'm sure perhaps you had a conversation about what had happened, or
Yeah.
maybe with a
Oh, we
friend,
did.
or
Yes, well, she was helping the lady whose small dog was attacked. She was. It was an interesting thing. She went. My wife's a very intuitive, kind person, so she went over to this woman and just started rubbing her shoulder and said, "You're safe. It's okay. Your dog's fine. It's gonna live. You're fine. You're safe." And the woman was sobbing and sobbing, and then she asked. She had to go into the house to get her phone because she was gonna, help with information and stuff. There was another neighbor there, another woman. She said, "Come over here and rub this woman's shoulders while I go in the house." And the woman just looked at her like she didn't get it. She just didn't get it. It was like, why would I do that? Or why would you say that?
Now, my wife had the instinct to do that because it was just, it was a young woman, maybe the age of some of my kids, roughly that age, and this woman also has grown children, but couldn't do it. It didn't register to take over, which was an interesting thing too. It's like you think
All by
about
itself.
caring
Yeah.
for somebody in a way after during a trauma, and other people that just don't have the bandwidth to do it.
Yeah, and it has to do with, with the trauma response. And your wife in so beautifully in her intuition did exactly, like she intuitively knew that that person needed to be made to feel safe. And this is when we talk about that relational neuroscience piece. It's like the co-regulation that your wife was able to bring in through her regulated nervous system and through her ability to kind of know to rub somebody's shoulder and to provide to be the safe beacon that was there for everyone. That's how co-regulation, which is how we are genetically and evolutionarily hardwired to get through these situations, is to co-heal and co-regulate through the situation. Now imagine if you're at the workplace and you've experienced a trauma such as this, and you go in for that co-regulation and that support from your supervisor, and you're asked, what could you have done differently, Bob, to prevent
The exact
that
opposite of
dog
what.
from attacking the other one? Like, Bob, come on now.
Yeah,
Like, let's
right.
think about this. What could you have done?
I could have not been born.
Well, that's what I mean. This is the ridiculous nature, right? And so, fortunately for the situation that you and your neighbors and your wife, navigated yesterday, I think, overall it sounds like a good outcome. Everybody kind of got through it, and yet it was still, it was heavy on your heart this morning. It was in your
Yeah.
thoughts this morning, as I'm sure it was everyone's.
Here's another
And
interesting piece of the thing. My wife and I were talking about. There were people that were home that were very close in vicinity. Even the people whose lawn that this happened on did not come out. Did not.
were you
Did not.
already there?
No. No.
No, so they didn't so they might have in their trauma response, their stress response, they might have been in the freeze state.
Well, free state, or they just didn't have their makeup on.
It's hard to say. Was it the bystander effect? Because a lot of times when there is an event, there's that bystander effect that because there's no one in charge, nobody knows what to do, and so
Yeah.
nobody steps up. I mean, you came out and you were the person in charge, right? I mean,
Pretty
you
much,
you
yeah. And
went
then, but there
flying
were
out your
there were some other neighbors that did come out. And do you want? And one woman got, wet paper towels to clean some blood, and I'm going to go get some band-aids if you want them. And then somebody, I don't know who, never found out, called the fire department, the EMTs, which we didn't really need, in my opinion. It was like, they're just going to make it more complicated and annoying. But they showed up, so it was a fire truck, and then they called animal control, and then those folks showed up. So but somebody called, and it wasn't anybody that was participating
in the
in
immediate
the,
circle,
yeah.
right?
So somebody had some sort of a sense like, well, I'm not going to help, but I'm going to call somebody
Right.
that can help. It was a lot of pieces of sort of the next day. We were processing it this morning, just talking about all the different sort of ways, that kind of what we're talking about. People dealt with this pretty violent, traumatic situation in that moment. But not, extrapolating into like what you're saying, nursing day after day, after month, years. I can really now you've really opened my eyes to what that is. I mean, I think about it with emergency response people and first responders, that kind of stuff. I can see that, but I never saw it in nursing. I just never saw it. So, I'm glad we're doing this episode because it is something that is important. And I think one of the things I was reading that there's we're going to be a shortage of nurses, particularly in the United States, by like 50% or something in the next few years.
So
Something.
if you look at the global statistics, the world is going to have half of the nurses it needs.
Oh my.
And here in the US, by the end of the decade, we'll be down 1.1 million nurses. So, and some of that is due to attrition. And again, just for the other geeks out there, it depends on who you read. So some estimates are 300,000, some are up to a million. So I do want just to account for the variance
Yeah.
in the literature for those of you who are counting beans out there, which I appreciate and
Yeah.
admire.
But it is going in
But
that direction. That's
right, but we do know, and so the narrative, it's really interesting when you start thinking about narratives that are in service to healthcare organizations and in service to corporate and venture capitalist organizations, right? You start kind of thinking about like this burnout narrative. It's really convenient because it places the blame and the responsibility on the victim so that the system and organizational factors that are contributing um, get a pass.
Yeah. It's very
Get a pass.
simplistic.
Yeah. And then you look at the quote unquote nursing shortage. And it's like, and I'm an integrative nursing professor. I educate nurses at a major university. And so it's like, the expectation is that we should just churn out more nurses. And so it's kind of this, hire to fire, churn and burn model of, well, yes, we're not going to take accountability for the trauma exposure or the staffing ratios or the fill in the blank, the resources or the violence or any of the other things. And that's not to make a blanket generalization that nobody cares, but I'm just saying here we are.
Yeah,
Right?
we're here.
Here we are. And so what we have is not necessarily a nursing shortage. And this is an important point. We have a staffing shortage because we are losing 25% of our new graduate nurses in the first year. They get into the hot mess of the healthcare system, and they're like, I don't think so.
Disillusioned and
I'm not. Why would I abuse myself? Why would I allow myself? This is what they're coming to me. This is what they're saying. I think I love myself more than to put myself in that situation.
I understand that. It makes complete
I understand it too. And so this is like in my work. So I founded a nonprofit. I did the research. I self-funded the research because I wanted to make sure that there was no bias in it. It's peer reviewed by experts, 5 experts, top in their fields on these topics, because I wanted to write a book and started a nonprofit where I and this work could be the safe haven for not only for nurses, but anyone who is affected by trauma, occupational related or personal, where there would be as though I were sitting in their living room, as I would in a nurse coaching session, as you and I are chatting here today, first person. Like, here I am. Here's the process. Let me guide you through this. And for the new or early career nurses, let me show you how you can learn the language of your autonomic nervous system and your vagus nerve, so you can insulate. You can insulate yourself from the effects of all of the things that we've talked about today. And maybe have a chance of, going on and having a meaningful career where you're thriving instead of just being in survival mode, which I'm pretty sure the nurse that you had the day you were in the hospital may have been short-staffed, under-resourced, and was probably doing their best to give good care and couldn't probably meet you where you needed to be met, because of external circumstances. And so that's why, I started this nonprofit and I have a 12-week academy so that people can get the support they need, because hospitals, they are aware of the situation. I'm working with hospital leaders on 4 continents right now, actually, and they're aware, but they don't understand. They don't understand. Like, well, we built them a gym, we built them a lavender lounge, we built them a wellness center, and I'm like, well, you're asking. It's like asking a firefighter to go sit in the burning building and meditate. Their nervous system doesn't feel safe there. That's where they're getting traumatized. So we need a place external to there, a safe haven where trauma healing can happen, where burnout healing, if it is burnout, which usually it's not, but in some cases it is as simple as burnout. There isn't, there isn't the trauma piece, but that's a minority.
Mm-hmm.
And that we can really start to, shift this paradigm. So it's nurses can and should, continue to advocate. And it's very difficult because and I'm going to say this is just with as much respect as I can, but as plainly as I can. The system is rigged, the game is rigged, and it's not rigged in the favor of the patients, and it's not rigged in favor of the healthcare professionals. How do we reclaim our healer's heart? How do we reclaim our professional safety? How do we reclaim our professional well-being? These were some of the questions I was asking when I was writing the book. And while I don't assert that I have the solution, I do assert that I took my one grain of sand that as part of it, doing what I can as one woman
Mm-hmm.
could do to make some sort of meaningful difference. Is it going to solve the nursing crisis? It is not. But is it a tool and a resource? And those who resonate with it, can it help? Yes, it can help.
That's how this stuff starts. Somebody goes, this is a direction that's not being looked at, and let's take a look at it. And that's, I'm sure there's people that go, oh gosh, why is she doing that? Well, she's
Yeah.
doing it because she understands it, and you're trying to, educate people into a solution. So if, problem is being recognized as just the first part, and then coming up with some kind of a solution, which it sounds like, you're really strong in being able to figure out what some of those things might be. And so if you're somebody that is, a nurse or involved in any of those kinds of things, this is a worthwhile thing to look into, which brings me to, how do people find out more? Let's talk about the book and the organizations and destinations people can go via the computer or whatever to figure out, maybe they want to know more.
My handle on all social media is, and I'm somebody's grandma said, keep your social media expectations tempered accordingly. But I'm at drlorrelaws.com, and that's DRLORRELAWS, and that's my YouTube, that's my everything. And I also have a website by the same name, drlorrelaws.com. And there I have a survey. You can find out if and how you've been affected. I have information. I have master classes that we offer for people who are curious, but maybe not ready to, like, I might need help, but I don't know. So we have sort of that, workshop kind of master class format. And then I have through my nonprofit organization, which is also on my website. It's called the Haelan Academy. And Haelan is the old English word for healing. So it's very dear to my heart. And we have a number of programs, one of which is the 12-week program, where we can really help people to either unwind the trauma that they've experienced. And then for those who might be like in the preliminary stages of burnout, or for new graduate or early career professionals, like, I don't want to end up here. And I hear this a lot, but I'm $50,000 of student loan debt, and I can't go do something else because
Yeah.
I've got the
Feel
student loan
trapped.
debt, and I feel trapped. Well, then this is a place that let us teach the language of your nervous system. There's 100 practices in the book that can be done in 30 seconds or less. There's a framework, 4-step process that so anyone can either heal, or they can prevent themselves from being a victim to all this occupational trauma that is not really being recognized and has been sort of swept aside under this gaslighting narrative, as opposed to saying, you know what, we have high trauma exposure here, and if we start really addressing that. And that's what I'm working with the hospitals, is like, let's start with the new graduate nurses. They're the most vulnerable amongst us, and let's see if we can help them to learn how to insulate themselves and navigate this in a way that keeps them safe, healthy, and thriving in their practice.
I enjoyed your comment about social media. I'm a grandma, and so if you're expecting her to be delivering this information in a bikini, that's not happening, is what she's really saying.
So not happening.
I, on the other hand, am wearing a Speedo as we speak. Thank you so much. God, that was like amazing. I don't even think we covered everything that, but the time has run out for us for today. And maybe there'll be more that we can talk about.
I would happily come hang out with you again, and we can take this. There's so many directions that we can go, and there's so much that can be shared. So for people, if you're interested in having me back, let Bob know. I'll come back.
Yeah, well, no, I'm interested, and we should do that. And I don't know what those topics will be, because I had no idea where this was going to go, which is always the most fun, and that was great. If you want to do another one, we should do that in the new year.
We will.
And
let's do it.
We'll talk about. We'll go woo woo next time. More woo woo than we did.
I live in Woo Wooville, so
right?
Let's go. Yeah, let's go.
We're neighbors. Dr. LORRE LAWS, the best. Thank you so much.
Thank you for having me.
Much appreciation for you folks listening to The Exploding Human. The website is theexplodinghuman.com. There is a YouTube channel that is The Exploding Human with Bob Nickman. Once again, I want to thank LORRE LAWS for being on the show. I'm going to have her back. We're going to be talking about some other cool things that we didn't get to in this episode, so stay tuned for that. Have a fantastic day. Thank you so much.